Hello, friends. Dave Bjork here, lung cancer survivor, patient advocate, and host of the Research Evangelist podcast. I recently got back from the ASCO annual meeting. It's the largest oncology conference in the world. And I'm doing a series of short interviews to provide some interesting research from ASCO for patients who could not attend. This series is supported by an unrestricted educational grant from Nuvation Bio. And today I've invited Dr. Sarah Goldberg, a thoracic oncologist and chief thoracic oncology at Yale Medicine, to tell us what we need to know about an abstract she presented at ASCO. It was about the COPERNICUS study with patients with advanced EGFR-mutated non-small cell lung cancer, and she'll tell you all about it. And Dr. Goldberg, welcome to the show.
Thank you so much for having me here. It's so wonderful to see you.
Awesome to see you as well. So let's just start by having you tell us about the research and what patients need to know about this important study.
Copernicus is a really interesting and fairly novel trial. It's, as you mentioned, it's a trial for patients with advanced or metastatic EGFR mutant lung cancer. We tried to make it a real world study. So we tried to make it as pragmatic as possible to have a broad range of patients able to enroll onto this trial. And did that by a variety of reasons, making a variety of ways, trying to make it easier for patients to enroll in terms of lab values, and patients were allowed to start treatment before they went on. Really unique in that way. And we also tried to maximize the supportive care, trying to minimize side effects from the treatment. And so there were two parts of Copernicus. One part is for patients with untreated EGFR mutant lung cancer. And in that part of the study, patients received a combination of drugs called amivantamab and lazertinib. Both of those drugs are trying to block the activity of EGFR, which is what's driving the cancer to grow in EGFR mutant lung cancer. There was another part of the study as well, which combined amivantamab with chemotherapy for patients who already received therapy. But the one that I'm going to focus on here is that first line study, the first line part, which is amivantamab and lazertinib. And I'll just also add, as I mentioned, the idea here was to try to not only treat the patients with this regimen, but to try to make it as tolerable as possible, minimize the side effects, and hopefully then improve overall outcomes for patients. This regimen was actually already studied in a big phase 3 trial called Mariposa. Patients received amivantamab and lazertinib as for previously untreated EGFR mutant lung cancer. What made Copernicus so different was trying to minimize the side effects as much as possible, adding antibiotics, which seemed to help the rash, trying to help with some of the nail issues that happen with this treatment, giving blood thinners to try to lower the risk of blood clots. And then also, instead of giving intravenous amivantamab, which can cause a pretty high rate of allergic reactions, patients received subcutaneous form, which does seem to lower the risk of those reactions. So it was trying to put everything together to make this as easy of a regimen as possible for patients to try to maximize how well people did.
That's awesome. So can you tell us in more detail about the prophylactic, the helping for the quality of life for patients, and why that is so important in this particular treatment?
So in the prior trial, Mariposa, that trial showed that this combination of drugs, amivantamab and lazertinib, patients did better. They lived longer compared to people who got just a single EGFR inhibitor. The problem with that study is that there were a lot of side effects. And we've had that regimen now available. It's been FDA approved for a while. And so we've used it a lot in the clinic. But patients sometimes struggle with it. They can have a lot of rash, mostly on the face, but also scalp. They can have a lot of nail changes and kind of infections in their nails. It can be tough for people. And there was also a pretty high rate of blood clots and then allergic reactions. So although patients did better and lived longer, it was very hard for people. And I think because of that, quality of life can be difficult on this regimen. So all of the prophylaxis that was put into this trial was trying to improve on that. So patients received oral antibiotics for the first several months on this trial, and then they switched to topical or cream antibiotics. And that was on the face and the scalp. And then they all received kind of a special wash for the nails, and everyone also received blood thinners. And again, all of that was trying to improve on what was already a very good regimen that improved how well people did, how long people lived, but now trying to make it more tolerable so they had better quality of life and could hopefully then stay on the treatment for longer.
And do you think that clinicians will be more proactive in terms of getting ahead of this versus waiting to treat the side effects after they show up?
So that's exactly what the idea is if we could get ahead of it, is that better for the patients? And there was actually another study I haven't mentioned called Cocoon,
Oh
where they
yeah.
randomized patients getting this treatment, amivantamab and lazertinib, to all the prophylaxis versus our standard of care, which is typically, like you're saying, if side effects happen, dealing with them then. And what that trial showed is it did seem to be better to give all the prophylaxis rather than waiting. So that really has become our standard, to give it ahead of time to try to prevent problems before they happen or reduce the risk of the more severe version of the side effects. And so I do think that's something that more and more we're doing. I know I do it in my own practice. So that already has been established even before the Copernicus trial. What Copernicus was trying to do is now take that and put it into a first line regimen, putting all the different prophylaxis and the subcutaneous form into a first line regimen to see how people did in that setting. So absolutely, prophylaxis with amivantamab and lazertinib is better than being reactive. We still sometimes have to be reactive and deal with problems when they come up, because it doesn't eliminate problems, it just reduces the risk and reduces the risk of more severe issues. But it is better to stay a step ahead and to deal with, try to prevent the issues instead of dealing with them after the fact.
Yeah, and it sounds really interesting to me because I feel like that is really patient focused. You know, when you mentioned the Cocoon trial, I think that's an additional step being taken to to really be patient centric about this treatment, which I think is very cool. As an advocate, I love that. So,
Yeah.
one last thing, do you think I was just talking with someone the other day, a doctor, about shared decision making and how it's things have changed since I had lung cancer years ago, but there weren't a lot of choices, and so now patients have choices. So, do you think that this will help patients, more patients maybe decide to choose this treatment?
I think so. You're right. We have now options for patients, and I always tell my patients options are good. It sometimes makes the conversations more difficult and nuanced, but options are always good. And in EGFR, it used to be pretty straightforward. We really didn't have a lot of options, but now we do. I think for when this combination of amivantamab and lazertinib first came out, I think people were very worried about the side effects. I know I was looking at the initial Mariposa trial. I was worried about that for patients, and I talked to patients about it, but it made it difficult to really say this is the right thing because I was worried about the rash and the issues there. But I think what Cocoon has shown us, and now what Mariposa, what all the different names, what Copernicus is starting to show us, is that when you give the prophylaxis, you can reduce the severity. And so I think this is an option that's a really good one for patients. There are other options too, which is always important to talk about. But I think these trials now make this regimen, laser as we call it, um, much more, I would say, appealing for patients, where the toxicity doesn't seem quite as bad. It still has side effects. There still can be rash. There still can be, we call it paronychia, this irritation and infections in the nails. Um, but it does seem less. So I do think that more people are now choosing it because the side effects seem less than they did initially. But it's not the right thing for everyone. And, some
Right.
people really don't want any risk of rash. And that is something that you have to take into account, because you still do see rash in quite a few patients. But again, we're making it better. We're making it less severe and more tolerable for people. I will just say, because I haven't mentioned yet, this trial, Copernicus, the data is still pretty early. It's very exciting. It does look like we're seeing great outcomes, but it's still pretty early. Patients haven't been treated for that long yet when we collected the data for this presentation. So this is a study that we're going to have to keep watching, right? We're going to have to look how people are doing at 6 months, at 12 months, how they're doing long term. Are people able to stay on longer? Are they able to do better because they're on this treatment with all the prophylaxis? So the early data look really exciting, and I do think we'll start to change people's minds about this and make it a great option for people. But we have to keep close watch on this and see how things look in the long term.
That's awesome. Well, you're always so thoughtful about how you talk about research, so I really appreciate it. And thank you so much for coming on the show, and thank you for all that you do for the lung cancer community. We appreciate you.
Thank you so much, and thank you for having me.